As always, I want to start by acknowledging the traditional custodians of the lands that we're meeting on. For me, I'm on Whadjuk Noongar Budja, and I want to pay respects to the elders past, present and emerging, as well as any First Nations people in the meeting today. And with the voice referendum coming up in just over a week in Australia, particularly important, yes, I'll be voting yes. It's been a really interesting debate, which I won't open that can of worms now, although who knows what will happen in the next hour. But I don't want to mess with, take any of Hayley's thunder from her presentation. So with no further ado, I want to introduce today's speakers. For those of you who haven't been before, this is part of what we're now calling the Australasian Justice Health Network, which is not owned by anybody, but it's a collaboration of research groups and people around Australia and New Zealand who have an interest in the health of justice-involved people. And at this stage, we're meeting monthly to have a webinar. We may introduce additional activities over time, but this is just a great place to start to build our connections and collaborations. Really, really thrilled to have as our speaker today, Dr. Hayley Passmore, who I've had the pleasure of knowing and working with in various ways over a number of years now. Hayley's based in Perth at Boorloo, and it's a lecturer in criminology at the University of Western Australia, and also has an honorary appointment at the Telethon Kids Institute. I won't, as promised, Hayley, I won't read your entire bio, it's in the flyer, but Hayley has an incredible background in child health, criminology, psychology, and a great deal of expertise and experience working in the justice space, particularly involving the Banky Hill study. And Hayley has a lot of expertise around FASD and neurodiversity in general, among many other accolades. Just to get on to Hayley, today's presentation is informed by her recent Churchill Fellowship, and the title is How Prisons and Detention Centres Internationally are Responding to Neurodiversity. I'm really looking forward to hearing it. Hayley, over to you.
Thank you so much, Stuart, and hi everyone. Good morning if it's still morning wherever you are. I'll just share my slides with you. Okay, can everybody see that? Good. So I too would like to acknowledge the Budja, the land that I'm presenting from today. So I'm on Noongar Whadjuk land, and I feel very, very grateful to live and work on Noongar Whadjuk land. And I'd like to acknowledge that I know that many of you are coming, or you're joining the meeting today from different countries throughout Australia. And so I just want to acknowledge the traditional owners of country throughout Australia, wherever you are. This is particularly important for the topic that we're having today, because we're talking about a justice topic. We're talking about prisons, we're talking about detention centres. And in the Noongar language, there was never any word for prison, for detention centre, for jail. So this is an idea or a concept that Wadjulas, colonisers, have brought with us to Aboriginal land. So I think it's really important that we keep that in mind. We're really talking about Western approaches when we talk about prisons and detention centres. The other thing is that we're talking about an intersection of health and justice. And this is, this network is a beautiful intersection of those two things. And Aboriginal and Torres Strait Islander people were the first lawmakers of country throughout Australia. They were also the first health practitioners. So acknowledging those roles as lawmakers and health practitioners is incredibly important. And we need to keep that at the front of our mind whenever we talk about health or justice, or health and justice. Okay, so as Stuart said, I'm talking to you today about my Churchill Fellowship. So I'll give you a little bit of an introduction as to what I mean by a Churchill Fellowship. So what I'll do is first give you an understanding of what an actual Churchill Fellowship is, in case you've not heard of it. I'll then talk to you about my topic. So what do I mean by neurodisability? There's lots of different terminology that's thrown around, and then the implications for neurodisability within justice settings. So why is this really important that we know about this? I'm then going to take you on a little bit of a journey through photos, because part of this trip is something that I actually can't explain through words. So I thought I'll show you a few photos from my process, and that will help prompt some discussion. Then what I'll leave you with is my observations, both promising and challenging observations. And I will just flag that it's only been a couple of months since I've returned, and there is a lot of different positives and negatives that I saw. And I'm very much still in the process of putting these positive and negatives into something that is practical and useful. And I'm sure many of you who work in the justice space can know that, you would have seen firsthand that there is always good things that are going on, but often they exist within systems that are fundamentally broken. And so trying to work through some of those observations is still an ongoing process for me. And then what I'll leave you with is my recommendations to date, and this is a list that I'm adding to always, but I've kind of divided it up into short-term, medium-term, and long-term recommendations. All right. So for those who haven't heard of a Churchill Fellowship, basically what the idea is to send an Australian overseas to learn about something that Australia has a gap in, a knowledge gap in. And that can be any topic at all. So I know several Churchill Fellows who have done it in entirely different topics. So I know someone who did theirs on snake handling, and they went all around Texas and learned how to handle particular poisonous snakes. I know several people that have done it on beekeeping, for example. So there's really a broad range of topics that you can do a Churchill Fellowship on. So my topic was, of course, looking at how prisons and youth detention centres around the world are supporting people who are neurodiverse. They send the purpose of the trip is to go overseas for up to 8 weeks. So that's the maximum period, to a number of different countries. So the countries that I was fortunate enough to go to as part of this were Wales, England, USA, Canada, and New Zealand, and sometimes to a couple of different cities within those countries. So I was away for 7 weeks, and it was over the period of June and July this year. And so that's why I just really flagged that this is very early in my kind of processing of that, and also in my report writing stage. So I still haven't yet submitted a detailed report about my findings. So this is part of my process. Now, for some of you, you might be really familiar with the term neurodisability that I've already used, but you might not have quite heard of it before, or you might not know why I'm using that particular term. So I thought I'd just flag some terminology up front just to make sure we're all on the same page. So one of the terms that we use really often is neurodiversity, and neurodiversity is the term that I always prefer to use. It's something that I think really captures the fact that we are all different as humans. All of our brains develop differently. We all function differently. And so neurodiversity is just a reflection of that. When we talk about neurodivergence or someone who is neurodivergent, we're talking about a person whose brain is different from what is typically expected. So if we look at all of the norms of how we typically develop, someone who is diverse from that particular norm for what we expect. Now, when we talk about neurodisability, we're talking about people that are so out of that norm, that those particular norms that we might expect, that actually the systems aren't responding in an appropriate way, and therefore that person is disabled by the environment that is happening around them. So neurodisability is a group of conditions that someone can either be born with or it can be acquired, so they can get it later on in life. And basically it affects our central nervous system, so the way that our brain functions, and therefore it might affect the way that we engage with the world around us as well. So just setting the scene for types of terminology that we're using. Now, particularly in the justice space, I've found that I have to use the word neurodisability for a couple of reasons. One is because the severity of the disabilities that we're finding really are quite profound, and that does really need to be recognised. And often when we meet with decision makers, with politicians, with people who are in government agencies who are have the responsibility of providing support for people who are neurodiverse, if we use the word neurodiverse, often they don't take us as seriously as they should. And so that's why we really have to use that word neurodisability to talk about these are profound disabilities that are affecting someone's ability to engage with the world unless the world recognises them and adapts appropriately. So some of the conditions that might fit under neurodisability are ones that you might be really familiar with, you might have heard quite a lot about. So things like autism spectrum disorder, language and communication disorder, intellectual disability, ADHD, traumatic or acquired brain injury, and then of course fetal alcohol spectrum disorder, which Stuart mentioned. But the thing that's really important to note here is that most people who are neurodiverse actually haven't had a diagnosis. And that's for lots of reasons. We've got, in many areas, we've got a lack of diagnostic services. We've got really long wait times. We've also got a lack of awareness amongst the community and sometimes amongst health professionals as well as to how to carry out that process. And particularly when we come to justice-involved populations, we know that the majority of people who have a neurodisability are undiagnosed, or in many cases, they're also misdiagnosed with something else. So whenever I talk to frontline justice professionals, I always talk about the fact that it really isn't in the justice context about a particular diagnosis. It is about a person's functionality, it is about their behaviours, and it's about how the system can recognise these things and respond more appropriately. So even if someone doesn't have that diagnosis, we should still be tailoring our approaches to their needs. And what we know from international research is that neurodisability is really highly prevalent in justice settings. So in prisons, youth detention centres, and in community justice settings as well. There's been a range of different prevalence studies. Most of them kind of focus just on one diagnosis at any time. Some of them might look at a couple of diagnoses. But what we found repeatedly, what we've seen across the world, is there's a real high prevalence. And so you can see here, communication impairments, 60 to 65%, 13 times higher in a youth justice population when compared to community peers the same age. Fetal alcohol spectrum disorder up to 36%, and that was found in Western Australia as part of our Banky Hill Detention Centre study, and that's 19 times higher than what we would expect for community-based peers for FASD. So you can see for all of these conditions, there is a high prevalence within justice settings. And at a higher rate than what we would see in the same age of young people in community. So it is really something that we need our justice system to be aware of, and we need our justice system to be responding appropriately. Now, one of the key findings to come out of our work in Western Australia, and I'm not sure how much you all know about the Banky Hill study, and I'm very, very happy to answer questions about it later on. I won't spend too much time on it now. But we were based at Banky Hill Detention Centre in Western Australia, which is the only youth detention centre for our state. So if you think about the size of Western Australia, that means that some kids are coming from almost 2,500 kilometres away down to Perth. So they're very far from country, very far from family, very far from home. Now, we had a multidisciplinary team assess young people over a couple of years. This included a paediatrician, a neuropsychologist, speech and language therapist, and occupational therapist. And we also worked with interpreters from the Aboriginal Languages Interpreting Service of WA to make sure that kids were always assessed in their first language. Now, through that process of assessment, we were able to look at 9 different areas of brain function. So things like memory and learning, communication and language, social skills, executive functioning, so our higher level thinking that helps us understand cause and effect, our overall cognition, motor skills, academic skills. There's something I've missed, but there was 9 in total. And what we found that when we assessed 99 kids over a 2-year period, 89% of them met the severe range of impairment for at least one of those 9 areas. And when I say severe range, we use the measure of -2 standard deviations. So quite a conservative measure. Sometimes in clinical settings, like speeches or OTs, might call impairment much earlier than that. So this is really quite a profound impairment we're talking about. Now, this 89% is just in one of those 9 areas. So 65% of the kids were severely impaired in 5 or more areas at once. 3 or more areas, and then 23% of the kids were severely impaired in 5 or more areas at once. So many of the young people had lots of different areas of their brain function meeting that severe range of impairment, and some kids up to 7 areas at the same time. So what this tells us is that we have a population of kids who have brains that are functioning in a way that is different to what we might expect for their chronological age. And what we also know is that most of these kids hadn't had these needs identified prior to our study. So they would have been engaged in all of these systems and services, whether it's education, whether it's contact with police, whether it's child protection, community services, health services, and then of course, justice and all the different stages of justice processes. And they hadn't had those needs identified. Now, I thought what I would do is just talk you through why neurodiversity is really important to consider for justice processes if we think about the way that someone processes through the justice system. So typically one of the first contacts that we have is with police. And if we are suspected of doing something, we can end up in an interview where we're being investigated. Now, that particular process relies on lots of different areas of our brain function. It relies on our memory. We might need to tell a story about an incident that happened. We might need to retell that story in a similar way over and over and over again. We will need our verbal language skills. So we'll need to be able to say exactly what we mean, but also be able to comprehend what is being asked of us in the first instance. We'll also need to be able to tell a narrative or a story in a chronological order. Now, if we have neurodiversity that affects these different functions, we might not be able to remember particular elements of the story, and that can come across as if we're lying or we're being non-compliant. We might have trouble putting things in chronological order, and again, that can be misinterpreted as if we're trying to hide something. So there's lots of different ways that that can be challenging. We're also really open to suggestibility. So if we get asked yes or no questions, we might say yes, even if we haven't understood it. And we're also open to confabulation, which is where our brain puts in missing parts of the information to help form a complete story, even if those missing parts aren't entirely true. So if we think about what happens after that, often could be court proceedings. Now, similar, there's lots of language and communication skills. There's a real high demand on language. There's higher level language skills used all the time throughout courts. Anyone who's been in a courtroom knows just how challenging it is to understand what's going on. It moves very, very quickly. So we might need fast processing skills. We might also need self-advocacy skills to ask questions about what's going on for something that does involve us. And all of these things can be really, really tricky for someone who's neurodiverse. Likewise, once we receive a sentence, often this relies on our ability to understand cause and effect or consequences for our actions. We know that this is our executive function skills. This can be really tricky for some people who are neurodiverse. It relies on our social cognition, so our ability to understand social rules and expectations, to be able to read others' emotions. We might have to show remorse, we might have to show empathy in that scenario because that's what's expected by those around us, and that could be really tricky for us in that setting. Now, once we reach compliance, so this could be whether we're giving a community-based order that we have to adhere to, so particular rules we need to follow, or it could be we end up in youth detention or in a prison and we're given daily rules and instructions that we have to adhere to. We have to be able to comprehend those instructions. We have to be able to remember them. We have to understand abstract concepts, so things like time and money, for example. So if we have a curfew that we need to adhere to, that's going to rely on our abstract concept understanding, and of course social rules again. So these are just a number of areas of brain function that these processes rely on. And again, that's going to be tricky if those are areas that are hard for us. And then finally, we have the supports and interventions, which normally is a really positive part of the process, and hopefully it is in lots of cases. But this is something where we see lots of supports and interventions that rely on talking therapy. And if someone really struggles with language and communication, even if we have the most evidence-based approach where we're working with someone using CBT, or if we are doing alcohol and drug counselling, for example, if we're relying on methods that are talking therapy alone and that's not adequate for that person, then we really are setting them up for failure. We're not providing a service that is accessible for them. So there's lots of different things that we need to think about, even at that end of the scale when we talk about providing support. Okay, so I'll move on now from neurodiversity and justice involvement in general to now take you on a little bit of a photo journey through my travels before I jump into some of the actual serious part where I talk about what I learnt. So I thought what I would start with here is the facility visits. So obviously the purpose of the fellowship was to look at how these facilities are responding. And so most of my time was spent visiting different facilities around the world in those particular countries. Now, for any of you who've worked in prisons for years or who have done prison-based research, you know that you will never, ever have photos within these particular facilities. That's something that is just simply not possible and for completely understandable reasons. And so this is the very rare case where this particular prison that I went to, this one pictured here, which is in just outside of Cardiff in Wales, they actually sent a media and communication person to follow me around the entire time on behalf of the prison so that then they could share that in their internal and external newsletter that their prison puts out regularly. So this was quite a different experience for me, where they were really happy to have me visit and very, very happy to promote that someone had come from the other side of the world to visit them. Now, there's a reason for this. This particular prison is a privately run prison. They are also the only one in the UK to have reached the advanced accreditation for autism practices. So this prison it's called HMP Park. There's a lot of information even on their own website about their particular neurodiversity approaches. I think the population, I might have got this wrong, I think it was around 1,700 when I was there. And they have a particular unit within this facility that is set up for people who are neurodiverse. Now, most of the neurodiversity that they are recording within this particular unit is for people with autism. And the original unit was built for about 75 people, but I think the capacity at the moment was around 100. Now, it was quite a different experience for me. This was the first facility that I visited. The minute that you walk in through the gatehouse, they had a billboard-sized banner all about how neurodiversity matters, with all of these different labels and information about the types of diagnoses that might fit under the neurodisability banner. And it was really quite odd, but also promising to see how it was the first thing that all of their operational staff would see the minute they walk through the door each day. But this is just one example of the facilities. So I visited several adult prisons, several youth detention centres. I was also fortunate enough to go to several other secure care units where sometimes they might be looked after either by child and family services in some of the different jurisdictions as opposed to justice and corrective services. And then I also went to some forensic psychiatric facilities as well, so looked after by health and mental health services. Now this here, the photo on the right-hand side is Barton Moss Secure Care. So that's one of those secure care facilities. So in the UK, there are different categories of youth offending institutions and secure care is one of them. And so this is one where it's almost kind of managed by the Child Protection Services, but all of the beds in that particular facility had been seconded, for want of a better word, that's not what I mean, put out for young people who are under youth justice. And so that was an example of a small centre. The capacity, I can't remember exactly, but it was under 20. So a really small facility compared to some of those really large facilities that I saw, like on the other side, where we had over 1,000 people. Now the facility just top left, that's one of the adult prisons that I saw in the UK. And that was really, really central to London, so Pentonville. That had around 1,800 people as residents. And this was really quite different because in contrast to the last facility that I spoke about in Wales, this also had a particular unit for people who are neurodiverse. However, it was very much in the same setting as other people, as other residents within that facility as well. So you can see here, there's 5 different levels of unit on top of each other. And so for people who were neurodiverse, they were very much, they were in their own unit, but then still very much, there's no protection from sound there, there's no protection from light. The minute that you walk in, there's several alarms going off. And so there's going to be lots of different things when we think about sensory overload that were just not feasible to maintain or manage or adapt for someone's needs when we have this kind of environment that you can see top left. So it was quite different to what I'd seen before, which was quite an isolated unit. Now here we have bottom left, this is a youth offender institution in the UK as well, where you have around 20 young people in a wing, but this was, I think, around 1,000 mark as well. So some of these are really, really large facilities that we're talking about, and then others are, 20 max. Some of them I think I saw were around 8 to 10 young people as well. So quite a difference in terms of the size and structure of some of these facilities that I saw. And the last facility visit photos that I'll share with you, this one here is from Canada. So this is the Manitoba Youth Centre. And one of the key learnings that I took away from this was about the integration of culture throughout every single step of the way at Manitoba. And so what I've popped here on the left is some of the tools that were used in my smoking ceremony by the cultural leaders at this particular youth centre. While we did the smoking ceremony in person, they also gave me a little takeaway bag, a Ziploc bag full of sage and of matches, which unfortunately I couldn't take on any plane home with me because I thought that might look a little bit sus. But the integration of culture and the bicultural approach to supporting young people was quite profound. And I'm going to come back and revisit that when I talk about some of my observations. Now, I've already alluded to the neurodiversity resources when I talked about that big billboard-sized banner, but this is something that I saw throughout many of the facilities that I went to. Now, particularly in the UK, as of March this year, every single prison has a particular role called a Neurodiversity Support Manager, an NSM. Now, some of those roles still haven't been filled, but all of them now have a position allocated for a Neurodiversity Support Manager. And one of those roles within the facility is to increase staff awareness through formal training processes, but then also through the development of resources and visual tools that the staff can refer to. And so this is just a couple of examples here where I was actually given so much neurodiversity awareness merchandise, almost, it felt like, where they had lots of all these booklets about how frontline staff, so prison officers, could consider neurodiversity in their practices, and then attached to their lanyards, so their keys, they would have the top tips as to how they could engage with people with different diagnoses. And this continued into everywhere I went, really. The amount of visual aids and really effective, tailored, practical visual aids that I saw across many of the systems were just really, really quite exciting and promising, because it's something that I've seen a lack of in many of the facilities. I think I've been to 11 facilities across Australia, and there's only been a couple that have really done this well. But for example, the probation conditions was developed in Canada. This was in Manitoba as well. And so whenever someone is given their community-based order or their supervised release order, and there's things that they have to adhere to, they would also get a picture version of that so that they can really quickly and easily understand what their particular rules or conditions are. And then over on the left-hand side, this was for people who were going into court. So almost like a comic book version of what that process is like. So who's involved, and what are the rules in that particular setting. And that was from New Zealand, I think in Auckland. Now, one of the other things that I was really fortunate to see was specific programs that had been developed for particular neurodisabilities within justice settings. So one of the most profound ones that I saw, and I think probably my biggest learnings came from, was the Manitoba FD Justice program. So this is a particular program in Manitoba that is embedded throughout several adult prisons and the youth detention centre, as well as in the courts, as well as in community corrections. Now, this whole team of people here that you can see on the left, most of them, there's also Judge Mary Kate Harvey in there as well, but all of the others work particularly in the FASD program, and they will provide a lot of one-on-one psychoeducation for people that have FASD, referring on to other services, advocating for FASD, conducting staff training, being in those facilities, ensuring that someone who has a FASD diagnosis has their needs recognised by the system around them. And I saw that in real time, how it works within the facilities and then in community justice settings as well. And this was particularly interesting because they also have in Manitoba an alternative court process for people who have a FASD diagnosis. So they have a court docket list just for people with FASD, and I saw how that worked as well in practice. So a real specific focus here on how we can support people with FASD. Now, the ladies that you can see in the photo on the right-hand side are both speech pathologists, and that was in Salford in the UK. So just near Manchester. Now, they have speech and language pathologists working in every single community justice office across that particular area. And one of the key things that they do a lot of, again, advocacy, they do assessments, they provide intervention. Most of their time is actually spent upskilling the community corrections officers as to how they can engage and use more appropriate language for people that might have a communication disorder, whether that's diagnosed or not. And one of the particular methods that they use, and they made me participate in, was called Lego therapy, which is where you're given a set of Lego instructions and you have to communicate that really clearly and using concrete language to your peer, who then has to build something out of Lego. And they do this regularly with prison officers as well as community corrections officers to teach language skills, and how as adults often we think we're communicating really effectively, but we're really not. Often we're not saying exactly what we mean, and we're not using the most appropriate direct language, particularly when we're working with someone who we want to understand and be able to engage in an appropriate way. So I've already said that I went to see the FASD court in Manitoba. And one of the things that was interesting was I actually didn't have any particular plans to visit courts throughout this fellowship. So my focus was really on those facility visits and seeing how things happened within those secure care environments. But just by the nature of talking to people and being interested in this space, I was invited to a number of different alternative court processes, which is always interesting to see. How things are being considered much earlier than prison and youth detention. So one of those, as I said, was the FASD court. I also went to a specific youth mental health court in Toronto. And then here I am at the Pacifica Youth Court in Auckland. Now, there are many different specific courts within New Zealand. This experience was probably one of the most profound and most impactful, where you see the elders, the Pacifica elders, working with the judge and with the family of a young person and with the young person to come up with a particular sentence or a particular set of conditions that would be the most appropriate for a young person. And everyone else who's typically involved in the court process is still involved. So there's police there, there's legal representation, but it was a real different approach to how we can do sentencing, really. And then one of the other key things that I thought I'd just have to add this in as a little plug for Churchill Fellowships is the extensive presentations and networking that you can do as part of it. So you get to be out and about and meet lots of different people. One of the highlights, I think, for me was going to the United Nations headquarters in New York and getting to speak to some key people there about child protection and about the rights of the child as well as disability and how we can recognise this in our youth justice settings. And here I am on the left-hand side in, I can't remember the name of the area, which I know I'll get in trouble for later, but this is where I met with a professor who has worked in neurodiversity and justice research for years and years, and I've followed his work for a long time, and he actually marked my PhD thesis. And so here I got to actually meet him in the middle of some mountains surrounded by sheep. So that was just a really cool experience as part of it, and something I'm very grateful for. But now what I want to move into is the serious part of this, which is my learnings and what this actually means in real time. So as I suggested, I've seen lots of promising observations, but there are lots of challenging things that I saw as well. So I'll start with some of the positives. One of the key positives that I saw was the integration, the real meaningful, tangible integration of health services within justice settings. So not just something tokenistic where we're just making sure that we are, preventing an incident happening, but providing real adequate healthcare within these settings using multidisciplinary teams and with adequate FTE. So that was something that I did get to see. And I know something in Australia we are really, really lacking in many areas. The other one was about the bicultural approach to health and wellbeing. And this is something that I saw in New Zealand and in Canada in the way that often the topic, that the leading conversation wasn't about disability, it wasn't about neurodiversity, it was about meeting someone where they're at and recognising their needs and then tailoring an approach to them. And this is something that is done really naturally in Maori culture, in many First Nations cultures. And I saw how that was embedded into justice settings, particularly in New Zealand, about how it was a young person first approach. And all of the different cultural determinants of health are prioritised, and then the social determinants of health follow on from that. So that bicultural approach was something that I think, I know we must do much better here in Australia. One of the key things you saw that I saw lots of different facilities of all different sizes and all different functions, but one of the promising observations was seeing those smaller purpose-built facilities. Because of not only is the environment much more appropriate for someone who might be neurodiverse, but there were really quite high staff to resident ratios in those smaller settings. And I saw this particularly with the health teams. Some of those health services that were providing care, it was almost, one or two health professionals to young people. So there really was adequate health care provided in terms of the staffing ratios. Whereas in some of those other facilities where you've got 1,800 people and a health team of, for example, 5 people, you're just not going to be able to provide adequate healthcare in the way that they need. I spoke earlier about the neurodiversity support manager positions that have been rolled out in all prisons across the UK. And that's something that I think is really, really promising to see that there is actual FTE allocated to recognising neurodiversity in these settings. And so even if other professionals around them don't have that awareness, there is someone whose responsibility it is within that facility who has that relationship with the workforce to keep neurodiversity in the conversation and on the table. And where I saw that working well was centres where there were visual aids all over the centre. Multiple staff, frontline staff, were talking about neurodiversity. They'd all gone through neurodiversity training, and then that could actually translate into practice change. So staff training, of course, incredibly important. The other key thing that I saw, again, particularly in the UK, was the use of allied health professionals, not just in the health team where we're talking about assessment and clinical intervention, but the use of health professionals within all of the therapeutic programs, the education programs, and the behavioural programs that were applied. So quite often I saw program facilitators working side by side with allied health professionals, or I saw the allied health professionals themselves running small group programs for people. So one of them that comes to mind, for example, was a speech and language therapist who was running regular groups about how we can learn about our own communication style and the types of things that might work for us. So that really ties into the next point about psychoeducation. Lots of those learnings that I saw and lots of the use of allied health professionals was all about psychoeducation for people who were in those facilities. So even if someone doesn't have a diagnosis, helping someone figure out what they're really good at in terms of functionality, what they might have struggles with in terms of functionality, and then how can we try different things to support ourselves, and how can we ask for help when we might need it. So lots of that psychoeducation was really common. And I actually asked every health team and every health professional I met, I asked them, how much of your time is spent doing assessment, how much is spent doing intervention, and how much is spent doing psychoeducation? And most of them would say we're mostly doing psychoeducation. So if we can't do the other stuff, if we don't have the capacity for the other stuff, we're still continuing our psychoeducation. And then, of course, operational staff with neurodiversity expertise. So beyond staff training, actually employing frontline staff who have existing expertise in the neurodiversity area is something really promising as well. Now, honestly, when I think about challenging observations, my list could be 5 times what I've put here, because in reality, what we know from many, many criminal justice systems around the world is that many of them are in complete turmoil. There are lots of challenges happening at every single stage of justice involvement, and I certainly don't present any of those promising observations without recognising that many of those are existing within services that are they are failing, to be honest. We only have to look at our recidivism rates around the world to look at how well we are not doing. And I also want to highlight that all of those facility visits that I did, those were the facilities that would let me in, right? So there are a number of facilities that I reached out to, that I requested access to, that I obviously wasn't given access to. There was also several facilities who I had a visit planned, and then within a day or a couple of days prior, that visit was cancelled quite quickly. Sometimes with a reason, sometimes not with a reason. And some of those reasons were quite reasonable. So one of them, they just had 7 people escape from a particular facility. And so, of course, I completely understand why a visit wasn't possible in those circumstances. But yeah, I just want to highlight that those promising observations are pulled out of really fundamentally broken systems. One of the key things that I'm sure no one here is surprised by, that was a challenge, is the lack of information sharing processes that I observed. Even within a facility, people using 4 different electronic data capturing systems, as well as paper-based methods, and then expecting other people in the centre of the facility to know what's going on and to be able to work to a plan for an individual person. It's just completely impossible when we have information sharing processes that do not talk to each other at all, even in a small facility. There was lots of inconsistencies with how people's needs were identified, really. So people who are neurodiverse, there was some formal screening and assessment done. Sometimes there were functional impairment assessments done, and sometimes there was just some random unvalidated tools used as well. In some areas, I saw a lack of interest from decision makers and from politicians to even consider neurodiversity within some of the centres. Sometimes I met with government agencies in some particular countries that said they'd never even considered that they had kids who were neurodiverse in their youth justice settings. And so, yeah, that there was a lot of work to be done. And particularly in some areas, there were some disabilities like FASD that had been actively excluded from their neurodiversity awareness approaches because it was too challenging. And the last thing that I'll say was about the application of therapies in appropriate settings. So I saw some amazing approaches, as I said, about allied health professionals running particular programs and providing therapy, either themselves or alongside other program facilitators. But sometimes I saw that happening in settings that were just fundamentally going to be ineffective. So, for example, if you think back to that picture I showed you where you've got a setting where there's 5 different stories of a unit on top of each other, and you've got constant sound, you've got constant sensory stimuli, you've got lights flickering, you've got doors banging all the time, and you're trying to talk to someone about, you might have some sensory processing issues, so here are ways that you could maybe support yourself through that, it is just completely inappropriate. And we're never going to be able to get, support that person and get their wellbeing improved and potentially change behaviours even within a setting like that if we are doing that in an environment that's just not appropriate. So that was something that I did see quite a bit, where we might have a building that was built in the 1800s that's just completely inhumane. And even if there's great things happening within that building, that doesn't mean that that building should still be used. So I'll move now on to the recommendations, and I realise that I'm really rapidly running out of time, so I want to leave time for conversation. Moving on to short-term. So short-term recommendations, easy to run out, routine evidence-based staff training on neurodiversity. And I don't just mean neurodiversity alone. Of course, that should be embedded in comprehensive cultural awareness training, trauma-informed practice, mental health training. Staff working in these kind of settings should know how to work with someone whatever their needs are. So that should be a given. We need the production and implementation of appropriate visual tools to support people who might struggle with language and communication. We need ongoing psychoeducation for those who are neurodiverse, whether they have a diagnosis or not. We need to, this is not rocket science, involve people within the facilities in decision makings about themselves, right? They are the experts on their own lives, absolutely. And if we're making decisions about their daily routine, a behaviour management plan, a through care plan, we should absolutely be going to the experts on what that should look like. And this ties into the last one, which is, again, of no surprise. What we need is basic and humane communication between all staff and between residents of the facilities. And a quick example of that is I spent time with a deputy governor in a particular facility who, he said, I'd been in this role for 30 years. I never knew anything about disability. 3 years ago, I decided, I should start learning about disability because lots of people I work with have them. He said he changed his style to just make sure that he answers every question that is asked of him. And if he can't answer it immediately, to let people know that he will come back and answer it later. And even that simple aspect, he said, has changed his engagement every single day within his role as a deputy governor. So this is not rocket science, right? This is just about engaging in a safe and appropriate way. And this is from the notes that I took during my meeting with that particular person. He provided lots of examples about how he and his staff now consider neurodiversity, simple things like for someone who has a sensory aversion to particular materials, so someone who didn't want to use a dishcloth and who was causing an incident every time they were required to do the dishes, getting a new dishcloth. You know, it's not rocket science, getting something that is a different texture that's more appropriate for that person. So he said success comes down to persistence, passion, staff training, information sharing, accountability, two-way learning, the small things, talking, but more importantly, listening, a high staff to resident ratio, and the right people in the right places. So it's pretty clear there. Now, the medium term, investment into overarching data capture systems. So we need comprehensive approaches to data, to capture data. We need consistency, and we need these systems to be able to talk to each other in an appropriate way. And it's just not happening. We need allocated FTE and appropriate, adequate FTE for allied health professionals within justice settings, like speechies, like occupational therapists. We need FTE for appropriate case coordination, because we can't really do comprehensive multidisciplinary assessments and approaches if we don't have adequate case coordination. And we need to increase staff to resident ratio, especially within health teams, but within all operational teams as well. Long term, this is the easy one, complete systemic reform across the board. If we break it down, we need to identify disabilities much, much earlier. This isn't or shouldn't be a justice issue. this should be happening in schools, it should be happening in health services, it should be happening when people are primary school age. We should know what people's needs are so that we can actually support them. We need therapeutic programs much, much earlier. They need to be culturally informed. They need to be developmentally informed as well so that they're accessible. And if we had everything right with the social determinants of health and the cultural determinants of health, we probably wouldn't need any facilities. But if we do, they should be small, they should be purpose-built, and they should be local and place-based. And that brings me to the end. As I said, I'm in the process of writing my report, and that will likely be published end of this year, early next year. But very happy for questions, very happy for email contact afterwards. And I'll now stop talking so that I can let others speak.
Thanks very much, Hayley. That was a terrific presentation, and you've covered a lot of ground there, and I'm sure have provoked a lot of thought, and there will be people who want to comment or ask questions. Look, I'll just invite people to unmute themselves and ask questions or make comments. If you prefer to make a comment in the chat, I'm happy to read that out so that Hayley can respond. But once again, thanks, Hayley. That was fantastic.
Thanks, Stuart.
Wei Chen.
Hi, Katie. This is a wonderful presentation, and it's absolutely music to my ears that people are starting to look at neurodiversity. In WA, neurodiversity is a service exclusion criteria for community service. So if you've got autism, ADHD, you are denied of service. And I'm working in the statewide youth inpatient unit. We see a lot of girls with autism, ASD, spectrum, ADHD. They are coming with self-harm. But I can see that a lot of boys will be going to the prison service, and they are really like, the stage 4 cancer that is allowed to incubate and metastasize until they get into a kind of like terminal stage. So I think this is really important work you're doing, and I hope that there's going to be a kind of like cross-discipline kind of advocacy for neurodiversity. And I think it's wonderful that you have got prison in which like that particular Cardiff Institute that people are so aware of neurodiversity in the population they serve. And that's like a really good example that we can really look up to. And I'm thinking that perhaps maybe I would like to contact you so our ward would have that kind of top tips and posters and things. The second point I really want to make is it's wonderful that you have addressed the language discourse aspects, and that's really is about the higher order language functioning. Is some people actually have basic language ability in terms of expressive and receptive language, but they can't use language for sequencing, for causal inference, and also to express themselves. And in the way is the poverty of writing, poverty of speech is the poverty of thoughts. And therefore you can't really understand what is happening and make sense of the world, and also to be able to express. So the ability to make narrative discourse, expository discourse, and make persuasion, so you can actually give your perspective to influence others. And all these are very, very important. I'm so glad that you are looking into all these. Really, congratulations.
Well, thank you so much. It's so lovely to hear from people who completely get it. And I couldn't agree more with some of those points. I'm very happy to continue chatting. That would be wonderful. Thank you.
Yeah, thanks, Wei Chen. I just want to read out quickly a comment from James Foles from New Zealand. James, do you want to just speak to that, or?
Oh, look, it's complicated because fitness to stand trial sort of varies across jurisdictions. So It's not the same in every jurisdiction, but the problem is when you go looking for cognitive impairments or neurodiversity in incarcerated populations, you'll definitely find them. And at the moment, we probably only identify the tip of the iceberg. So we're grappling with this in New Zealand, that the case law around fitness to stand trial is kind of changing. But so there's probably a lot of people out there that are marginal in their fitness to stand trial, and it's contextual. So the more complex the charges are, the higher the threshold to be fit. But there's not disposition options for those people. So if they're not suitable for forensic mental health services, they don't have a treatable, mental illness, but they're not intellectually disabled, there's struggle to know what to do with them. And the fetal alcohol spectrum disorder kind of fits in that category, but there's other people that are problematic, traumatic brain injury for other reasons, autistic spectrum disorders and other groups. So it's something that we're grappling with in New Zealand. It varies from jurisdiction to jurisdiction, but I'm sure there's similar parallel issues going on in Australian jurisdictions as well.
Yeah, James, completely agree. And I'm not a legal professional, so I'm never the best to kind of explain these things. But what I find from the research element is everything focuses on one diagnosis only rather than neurodisability overall. So it's really hard to piece the information together to look at what's happening across the board and across jurisdictions. So yeah, definitely a challenge. And I know that there's lots of people who are now kind of speaking out within court processes about that. But again, it's very ad hoc how it seems to be happening. Thank you.
And I see perhaps the last comment from Kiri Von Clear.
Yeah, hello. Hi, can you hear me? Thank you so much for that wonderful presentation. It was, I'm saying hello also from the same youth ward in WA where AJHN is. And yeah, I just knowing the latest evidence we were just looking at the other day about incarceration in females and the connection to hormone sensitivity, and that that there's an 8 times higher risk of incarceration during premenstrual sort of times in the cycle. I was just wondering, did you see any evidence there of like sort of screenings for these kind of things like PMDD in neurodiverse individuals? Yeah.
Nothing at all.
Okay.
But that is fascinating. Yeah,
it's a huge area that's sort of special interest area. So on the youth ward, we'd love to keep in touch with you, Hayley.
Absolutely. And that ties into what Chen said earlier about typically it could be because of the way that we are conditioned by society, but typically we see lots of internalizing behaviors in young girls and then externalizing behaviors in young boys. So in the justice settings, we're not really thinking about it in terms of young women. So
it's going to be really interesting. Thank you.
I'd just like to add the thoughts that in ADHD female, the rate of PMDD is much higher. It's like 45%, whereas the general population is about 5%.
Wow, fascinating. Thank you both.
Hayley, I'm mindful that we're at time, but clearly what you've been talking about is really resonating with people. And I've seen at least one person in the chat saying they want to be kept in the loop for other presentations you're giving. So there's definitely an appetite for more conversation about these very important issues. Unfortunately, we've run out of time for today. Just before we go, I just want to give a quick plug for our next presentation, which is happening on the 3rd of November, Associate Professor Ruth Cunningham and Dr. Paula King from Otago University talking about wellbeing outcomes after incarceration in the New Zealand context. I'm really looking forward to that one as well. But in the meantime, those who are still here, please join me in thanking Hayley for a fantastic presentation. Thank you so much, Hayley.
You're so welcome. Thank you for having me.
And we'll look forward to seeing you at the next one. Be well, everyone.
Take care.